Good afternoon, ladies and gentlemen, Mr. Chairman. Thanks again to Dr. Kranz and Dr. Masson for the invitation here. My role now will be a little bit more basic, more humble. When should we stop with that? So maybe we'll find some agreement here. Okay, I should try to get it started. Oh, it's there. I know. Thank you. Okay, in trying to get to the point, I will go through some issues, some of the data of the need for repeated ablations that are here, and I think the core of the discussion is here, when and how to stop performing ablation again. And we try to take it also answers from our database, overview the issue of redos, and how and if it is possible to define a score to predict evolution to persistent AFib that basically is the hallmark for the futility of an ablation. And finally, some conclusions. I'm just quoting a couple of papers here because they were kind of landmark early publications. The first one is here, the combined experience of Bordeaux, Australia and Canada on about 100 patients with a mixed population of paroxysmal persistent and long-standing persistent atrial fibrillation. I think that what the two survival slides show here is quite clear. Single procedure success at 1 year is kind of very low, and that can be enhanced by repeat procedures. That is, so this seminal information set the stage for the perception that is not futile to perform again procedures, so repeat ablations can lead to a better result, and that is also has been stressed in a stronger way by the combined experience of our colleagues in Tokyo on more than 1,200 patients suffering only at presentation from paroxysmal atrial fibrillation, where they very clearly were able to prove that even in this so-called easy setting, higher success rates were achieved by multiple procedure, and actually they had a 27% rate of repeating the procedure. Does it make some sense to repeat a procedure of ablation after a failure? We have, I think, the single center study that provides a clear answer to this is that publication by Dr. Pokuleshov that randomized patient after a primary PVI procedure to implantable recorders in those that recurred, and then randomizing patients that were very closely followed into a group that underwent a re-ablation procedure and a group that underwent only treatment with anti-arrhythmic drugs, thereby showing quite clearly here that patients clearly get a benefit from a repeat procedure over those that received anti-arrhythmic drugs, both as recurrence rates and also burden of atrial fibrillation. So it basically makes sense to repeat the ablation procedure when the patient recurs. And that also is reflected by the guidelines. What should we do? Of course, everybody agrees what to do. The initial stage is PVI, and also the second procedure is aiming to assess what is the PVI status. So that is very clear. If the patient has reconnection, then of course try to get persistent isolation of the pulmonary veins. Otherwise, and then here the black box opens to a lot of options that we have already discussed, and none of these has been shown to consistently provide a significant advantage. So I'm pretty much in keeping with what Karl-Heinz says. Probably key is really to achieve and to prove persistent PV isolation. That, however, is only one problem, because there is definitely a role to study what to do in patients that recur in spite of having PV isolation. And these are really the bad guys, as seen here. This study by Dr. Kim in Korea clearly shows that if the patient that comes at redo has PV isolation, then, then it is bad news, because the recurrence rate is much higher, and that is probably related to a much sicker substrate. And here, that is also stated in a much more quantitative way. If some of the PVs are isolated, results are intermediate between those that have complete isolations and those that require PV isolation to be performed. So I think that not only clinical, but as well EP assessment of the status of the patient that comes at redo for a failed procedure is of paramount importance. Now, in spite of this, that seems quite obvious, if we go and search through literature, the scoring system that has been devised to assess the risk of recurrence, they only have based on clinical data. So we can, I just picked 5 out of the many, the CAP AFib, base AFib 2, Allermack Hatch, and the recently published Apple from Leipzig. And you see, I think that you can take the picture of the slide and go to literature. I don't want to take much time. But you see here that basically all the descriptors that have been taken into account are clinical data. All of them, including atrial size, age, pattern of arrhythmia, long-standing persistent duration of the arrhythmia, some having measures of dilatation of the atrium, some other comorbidities like renal insufficiency, smoking habitus, body size, cardiomyopathy. But all of that is quite clear. So we have some clinical data that kind of mark in a very negative prognostic attitude the patient that will recur. There are some very basic, very easy studies like the Allermack, 2 or 3 issues. The CAP AFib has a much higher count of descriptors, but again, the story is quite clear. According to each of these experience, the more points you get, the higher the likelihood of recurrence. Let's see what is, at least what has been for us, the perception of repeating the procedure. The database that we have been working with has been gathered in 6 years between January 2010 and June 2016 on 1,800 patients, 1,800 procedures, 1,463 patients, mean age 60 years, mostly males, 26% having a redo procedure, 62.9% paroxysmal AFib, 26 persistent, and the remaining long-standing permanent or atrial tachycardias. An overall rate of redo of 375, and this is the population study that I will mostly focus on. Target data is follow-up, which is paroxysmal AFib, any documentation of paroxysmal AFib or evolution into persistent permanent atrial fibrillation, as well as complications. So to really weight the utility or the futility, the gain or the risk of performing a redo procedures. Now, the other thing that I have to mention here is that many of our patients were discharged and remained on long-lasting treatment with antiarrhythmic drugs. So I really wonder when I see studies of all this huge amount of patients off antiarrhythmic drugs. In our series, almost 70% of the patients remain on antiarrhythmics after the procedure. Now, out of this busy slide, I would like to draw your attention on the percentage of complication and the percentage of patients that turned into persistent AFib at follow-up. These are kind of hard endpoints to measure. Should we offer a second procedure, yes or no? Now, the analysis of this data is quite clear. The rate of minor and major complications is exactly the same at the first, second, third, and we didn't mention 4 and 5 procedure because the numbers are very low, as the number of patients that went into persistent AFib at follow-up after that procedure. So under this standpoint, there is no real sign of futility. Any procedure, when this is undertaken, may bring about substantial advantages. So there is not an absolute limit to the number of procedures, although common sense tells you that probably after 3, 4, it's enough. And it is enough not probably because the patient has enough, but it is enough that because probably you might have reached your endpoint, which is PV isolation, And you have a situation that you cannot no longer change with the further ablation, I guess. Again, in our experience as well, we were able to perfectly duplicate the data of the group of South Korea. That is, a patient that presented a redo with total PV recognition had a much better follow-up, because once the PVs were definitely disconnected, then they were in sinus rhythm. Whereas the issue is patients that come at redo with PV that are isolated do actually represent a major problem, because we have nothing to do with the catheter procedure. In keeping with this, we tried to add into our score some EP predictors. Presence of scar, dilation of the left atrium, and we are in the process of adding other describers like a presence of atrial tachycardias, PV isolation status, and concomitant flutter. More numbers are needed yet to come to statistical significance in this model. Now, any of this is obviously quite clear. Any of these descriptors has a very strong significance by itself. Scar, yes, no. Volume, higher or lower than 90, yes, no. Sex, paroxysmal versus persistent, presence or absence of structural heart disease. So all of these can have a role in the decision-making process. But again, I think that probably being able to add some specific descriptors will probably be very useful for the future to decide whether or not offer the strategy. The statistics were kind of accurate, and you see here we went to the number of 5 as a cutoff to really prove that you are in need to perform another procedure, yes or not. And here is the crude number. You see the higher the score, the higher the likelihood of getting persistent AFib at follow-up, and here there is no magic, but once you reached 8, 9, probably then the curve really starts to growing, and that is basically the hallmark for so-called futility of a further ablation attempt. Now, why do I say that? Because now probably we have sound ways to go to a point of sinus rhythm maintenance, at least in our institution. Once we are on target, left atrium more than 100, redo with isolated pulmonary veins, the case is no longer for us, it's surgical. So then we have to decide whether we can support a full surgical scheme, MACE, or a thoracoscopic approach of isolation of the posterior wall. So we have choices. Although actually we were not able to prove that any attempt is bringing along an additional rate of complication, I think that probably after 3 cases, one should really offer the patient to another option. This scoring system, it's including, and it is kind of unique on its own, both clinical and EP data, and I hope that in the future we will be able really to prove prospectively that it works. Thank you for your attention.
Thank you very much. To show some light on some possible predicting score, are there any questions from the floor? So do you think, based on this score, you would be able to distinguish patients which are no ablation at all anymore should be performed, and ablations where it still is useful to try to attempt a thoracoscopic approach, or?
Yes, I guess so.
Yeah.
I guess that probably the combination of some clinical descriptors and some EP parameters really should drive the decision to really abort the EP procedure, favoring either a MACE or a thoracoscopic posterior wall isolation, and probably voltages on the other areas of atrium being healthy, yes or not, favoring a kind of intermediate approach like thoracoscopic over the MACE.
And are you already including data from patients
Yes, I am.
who had thoracoscopic? Oh, yeah. Oh,
Yes.
Okay. I'm looking forward to that. Yes?
Paolo, in the United States, most of the time in the pulmonary veins are really permanently isolated. Our colleagues even earlier advocate to stimulate the heart to provoke extrapulmonary triggers outside of the pulmonary veins. So in the description of your strategy, when the patients had isolated pulmonary veins with a very poor outcome, as well as in the study by Kim, what was the strategy that you applied? Did you look for extrapulmonary triggers, for instance? What was, when you noticed that the patient has isolated pulmonary veins and he came for atrial fibrillation back, you didn't send him home without doing anything, right?
Yeah.
You did something.
Yeah, exactly. That is why I proved that it wasn't working. So now that we have data that at a certain point the procedure doesn't work, I think.
So did it include to look for extrapulmonary trigger too after the pulmonary veins were
not
isolated?
systematically, because this is database data. So some of our colleagues were really hardly working, trying pacing, adenosine or isoproterenol. Some did not. So it's not, and also the number are so low that when you try to take these numbers into a database to look for significance, you lose it. So I doubt that ever, from the statistics standpoint, that will come as an independent predictor. Although biologically speaking, I think that this is definitely correct, because many groups have identified in non-pulmonary firing a cause for treatment. Then again, I think that from the statistical standpoint, it will ever be an issue because they are definitely small. It's a small population.
Because I personally believe that this is the right time to do something in addition. Once we have proven that the pulmonary veins are isolated, we still don't know what to do, but it would be nice to look into that patient population with isolated pulmonary veins and maybe compare the different strategies. And of course, in a randomized trial, you could leave at least one group without any additional ablation and just take them as a control group, and then you could judge and value what can be added by either extrapulmonary vein triggers that you ablate or whatever type of ablation that we have discussed here today.
What's the incidence of extra PV triggers in your experience at redo?
Actually, Francis Machinsky, who is the father of extrapulmonary trigger, he just presented in 2016 this recent updated paper, and they found a total incidence by delivering isoprel at a dose of 20 micrograms per minute over 10 to 20 minutes, which is a very high dose over a rather long period of time. We don't do this. We just give a short application, and they found 10% of patients that had sustained PV triggers when they delivered this dose. Now, interestingly, when they compare it to the patients in whom they could not trigger an extrapulmonary trigger, the outcome was not different in compared to those where they ablated the extrapulmonary trigger. So again, this was at the time of the initial study. That was not at the time when the pulmonary veins were isolated. So that is, for me, a completely different story. I'm just asking because I'm always interested in the group of patients who have isolated pulmonary veins at one point in time. What happens to them if we do whatever? That I believe, is the challenging question for us, for all of us, over the next couple of years.
One thing, though, Heinz, the vast majority of those that come with recurrent field having PV isolated do have bad atria. So although I sympathize with you, I think that the bulk of the issue there is really to be practical, to get to more robust endpoints of subset modification that probably will be achieved only surgically, I guess.
Yuri?
Is there a patient category that you would immediately send to surgery?
Yes. A patient that has kind of long-standing, that is, for me, more than 1 year, more than 100 mils of in left atrium, I think that it is kind of hopeless to start with. So really, in our database, I did not present this data, but we can cut off. Sinus rhythm maintenance is 82% in the paroxysmals with a volume less than 90. Is 50% in early persistent, 90 to 120, 6 months, and it is 20% when AFib is lasting longer than 1 year and the volume is higher than 120. So this group, I think it doesn't make any sense, at least to send to ablation in our institution.
So the question would be, once the PVIs are isolated and you're searching for something extra to isolate, is the approach, should it be a mechanistic approach that you try to map it, and do we have the current technology to find what would be the cause, or should we go, me talking to a surgeon, to predefined anatomic and just ablate whatever you can ablate in a linear lesion set with a transmural lesion, and then go for anatomy and not for mechanism?
Yeah, you know that well. The surgeon goes for anatomy. So the endpoint is just anatomic. What we add, you might know that because we published with Stefano a paper of the EP findings in his population that underwent MACE. And now routinely we remap after 2 months both the thoracoscopic or the MACE with arrhythmia, looking for gaps or bridges to the veins or other situations. So I think that what you can ask for in a surgical session is nothing that is electrophysiologically driven, at least in our institution, just crude isolation of the segment, yes, no. And I think that now it has become routine at our place to do a completely remapping study at 2 months after that, to add and correct for possible gaps.
In symptomatic patients?
Anybody.
Anybody?
Anybody.
Ooh.
Do you find a lot of PV reconnection in those patients?
Some. Of course, when you do the PV, the thoracoscopic posterior isolation, if you have a gap, that instantaneously goes into some pulmonary veins by definition. Although the PV area had not been mechanistically addressed, functionally speaking, the PV gets into the field. And so there are two categories, either gaps that are bringing to PVs or gaps that are leading to circuits. So basically they are both capable of causing troubles. And I think that I think that Stefano was an excellent operator of MACE, but we honestly admitted a very high recurrence rate of atrial tachycardias over the long term, over in 5 years. So then that prompted us to make it. You seem to be skeptical, but we have to see. I think I understand that to take an asymptomatic patient to a full EP study may seem a little bit unwarranted, but I think that over the long term, these are patients for whom you think you deserve the most effort. So that effort really should be really honestly stated and probably fixed if the endpoint has not been reached. And well, we have to see. I think it's a nice thing also mechanistically to see where a surgical ablation phase where and how maybe the surgeon can improve his/her operation skills.